welcome Dr. James Torrens, and thank you for having a conversation with us at Talk Lipoedema. You're a GP in Central Scotland, and you also work with the NHS Healthy Weight Services. So it's great to have you here today. I wonder if you could begin by telling us a bit about your experiences of working with people with lipedema.
Of course, thank you very much for interviewing me. I've been a GP for about 7 years now, and a doctor for about 15. And throughout those times, I've encountered lipedema quite a lot. And probably only the last 5 years, I'm actually coming to grips with what it actually is and its sort of classical presentation. It does come up quite a lot with quite a lot of consultations, whether it be from patients in general medicine to A&E to orthopaedics, and it's very misunderstood really, and there's not much knowledge about it within the current services. Recognising the shape is quite good, and it's quite useful for me in clinical practice.
Yeah, and you say it's misunderstood and maybe not acknowledged. Do you think, particularly thinking about doctors, do you think doctors learn about lipedema at all in their medical training?
I think we're taught more about sort of edema from heart failure or primary lymphedema, and I think that's the sort of classical presentations that we're always taught. When actually I would say that you would see more lipedema than you would lymphedema, and certainly at med school, because it's system based, we wouldn't be taught very much about it, but you would see a lot more in presentation in general practice than any other specialty.
Mm-hmm. And just thinking about your own experiences with people in general practice, when you see a woman who you think has lipedema, how do you manage that? I'm thinking about, do you do an examination? Do you take a history? Do you have time for that?
Often we would have time to look at it if it would be the sort of primary consultation. You know, if they were in to talk about their sore legs or their swollen legs, we would see a lot of people with swelling of their legs, and they're looking for some answers to why it's happening, and where to go on from that and support. We would struggle often with, consultations about it, sort of saying in the heat they would swell and they're sore at the end of the day, and lots of female patients would be quite conscious of the swelling within their legs. And we would see quite a lot regarding that. Often it's part of a larger consultation. They would say, I'm having problems with my legs as well, would you mind having a look? But often it's part of another diagnosis. So they would sort of say, well, apologies, look at my legs. I'm very self-conscious of my legs. And actually when you open that conversation with them and say, oh, actually you've got lipedema, has anybody ever said that to you? Then they normally are quite pleased that someone's made a diagnosis of their legs, and they're quite happy to talk through. But once we make that diagnosis, it's knowing the right place to point them to and to get them further support for them. That's the big issue for me.
Yeah, at Talk Lipoedema, we're really keen that people have a diagnosis early, but we often hear from people who have lived with symptoms for many years and haven't had a diagnosis of lipedema. And I imagine for GPs that must be quite difficult, given the restraints of time. It must be quite difficult. So just wondering, what advice would you give to other GPs in making a diagnosis of lipedema?
It's all about confidence and recognising it early with patients. And once you've seen one classical shape of lipedema of legs, then you actually feel more confident in the next time that you'll see it and you'll recognise it. Unfortunately, at the moment, we're probably recognising it later when they have complications such as ulcerations in the legs or increasing pain, discomfort, and it's often trying to get things like cellulitis under control. And actually, if we noticed it from the start and said this is lipedema and offer them support at the start, we probably would cut down on those kind of infections and problems.
It is a complicated picture sometimes, though, isn't it? Because we might have a young woman just around puberty who starts to develop symptoms, right the way through to older women who've perhaps lived with symptoms for many years, who are having problems managing their weight or having chronic pain. So I think, I imagine for GPs that must be difficult to identify lipedema within some of that and to exclude other conditions. And I wondered, could you say something about the sorts of other conditions that you think a GP needs to exclude as well?
The subject of weight loss and weight gain and weight management is always a really difficult one to discuss, and it's much easier for me as a weight loss clinician to talk about that. And I think that's the difficult hurdle is to start the weight management conversation. However, at the time when it's brought up when they've got swollen legs, obviously the main problems such as heart failure would be an important one to address. The other ones would be the sort of orthostatic edema of the legs would be the main reason you would see more in the elderly patients or people on side effects of medications. Other things would be acutely swollen limbs. Your DVTs would be the other thing that you wouldn't want to miss. I think the main thing that address the lipedema for me is that it's often quite confused with osteoarthritic pictures of the hips, ankles and knees, and also fibromyalgia. So lots of patients with lipedema get lots of pain within their legs, especially down the fronts of the legs and down into the calves where the swelling is more prominent. And I think once we get those managed and the appropriate support in place for those, the patients often feel a lot better. If you don't do that, often patients are given medications to try and help with that pain and discomfort that they're getting, because when they're on their feet all day, especially at work, that they'll have pain. So these patients often are prescribed things like pregabalin or amitriptyline or cocodamol to try and get over this pain, whereas a simple support might be more appropriate.
And it's really hard though, there's a mixed picture here of different conditions overlapping with lipedema as well. And I'm just wondering, have you anything, your thoughts from a GP perspective on managing the mental health, emotional aspects of lipedema?
I think the main thing that we need to address is probably the body dysmorphia with it. Lots of people are very conscious about their bodies. Lots of people have low self-esteem, low confidence issues. And when we see these patients, specifically for a weight management problem, that the body dysmorphia has escalated over years, and they're really self-conscious about their weight and their overall shape and appearances. And it's easier for me to address this in weight management because we have specific health-based interventions that can address these issues, and psychological interventions which are centre around weight and weight management, which is quite good. But in the wider sort of population, there wouldn't be much to address body dysmorphia with psychological services. They do exist, but they're a stretched service with mental health. So it's a big aspect to address. And I think if we were to sort of recognise lipedema earlier, I think it would reduce the rates of body dysmorphia and make lots of women predominantly more confident within their bodies and feel better about themselves. So I think early recognition is the key for getting this sorted.
Yeah, and so it is interesting because we have got evidence from research that people with lipedema do have problems with depression, anxiety, disordered eating. So it sounds like what you're saying is perhaps there aren't the psychological services available to support these people.
Yes.
And I'm just wondering, have you any thoughts on how that could become part of a referral pathway? I wondered.
I think the referral pathways that exist for weight management would help with that, and I think in a lot of areas we are working in that sort of joint approach. So it's more looking with health and psychology together and how we can support this with also measurable management of weight, which is useful. I think using the sort of medium of online programs for self-CBT services specifically for body dysmorphia is also really useful in quite a lot of these cases, and can be quite quick, effective, and quite a lot more interventions than one-to-one psychology input would have. So I would be a massive advocate of online CBT programs for this. It'd be very quite useful.
Yeah. And So thinking about, we're starting to talk about pathway here, because Talk Lipoedema would like to see some sort of pathway for diagnosis and management of lipedema and support of people with lipedema. So I wonder, how far do you think we are in achieving that?
I think we do have the joined up working there that's available. We probably don't recognise that as we already have it. For me, recognised pathways work really well for patients, and it helps with everybody that's involved in patient care, in that, you know, it might be that the practice nurse sees the patient and refers on. It might be that the chronic disease management nurse sees the patient and refers them on. But we need somewhere for them to go to and be seen. So for me, we need a recognised pathway for everybody within Scotland to be seen. So if someone was to start that conversation with you about your lipedema, this is who you would be seeing. When they go to make those referrals or go to be seen for those referrals, and they're said, well, actually, we don't deal with lipedema, we'll deal with lymphedema or cancer-related lymphedema, it is really quite a setback for the patient, and they're quite upset. So recognising pathways and getting those patients seen and dealt with appropriately by the right professional at the right time and place is key, and that's something that I would like to work on, specifically more from the weight management point of view as well, that we could do a bit of joined up working and get this recognised and dealt with more appropriately.
That would be wonderful to see a recognised pathway to bring some equity across Scotland and beyond as well, wouldn't it?
It would be.
Definitely. And so it strikes me now that we're thinking about education of healthcare staff, because you were mentioning perhaps if somebody with lipedema goes to practice nurse, perhaps they don't have the confidence and skills to deal with this. And I'm wondering, any thoughts on how we would go about addressing that gap in awareness and education?
I suppose it needs to be for everybody involved. You know, it needs to be sort of across the board available educational sessions, whether that be online modules via Turas or even just educational leaflets, pamphlets, or just to raise awareness of what we need to do to move forward and get this recognised. Obviously, we need everybody to be able to recognise lipedema, but also people to know how to treat it as well. So if anybody was faced with a patient with lipedema, they'd know the basic steps to do to get the patients seen and sorted.
Yeah, and we know also many of the people that we hear from at Talk Lipoedema have got problems with knee joints, hip joints. So we would like to see the early intervention actually having an economic effect in terms of saving money in the NHS in the long term.
I think it is part of the wider picture of healthcare, and I think it's especially with the knees and the hips being done, because often these patients would come and they wouldn't have their lipedema addressed or their weight addressed, because it's a difficult conversation to have. And the first point of this conversation might be from the orthopaedic surgeon, you know, saying that you need to lose weight to help with this operation or to help with the post-op recovery period, and often sets them back quite a bit. And for someone that's already a bit self-conscious about their legs in chronic pain, it's a difficult conversation to try and come back from. So if we could early recognise that they've got lipedema, and treating the lipedema might help with their mobility, which might help with their knees, it will be a win-win situation for patients all around.
Absolutely. So as a GP, have you had many conversations with your colleagues, doctors, nurses and others in general practice and primary care about lipedema?
For me, I've had several conversations with my colleagues about it in over the last couple of years, because it's, you know, obviously if I see lipedema and I say, well, actually, can you please go to the treatment room to get your legs measured for stockings? And it's often a sort of a breakdown communication between the clinicians, because they may not understand why their patient's coming to see them and what needs to be measured for their legs, or even the indication for support stockings, because because everything that we would do at the moment would be sort of not regimented, but, you know, fairly fixed in their ideas of, you know, this for ulcer support, is this because of recurrent cellulitis, or is this appropriate, or even have the patients been measured for peripheral vascular disease, because if if they haven't had ABPIs, then they can't have support stocking. So it's getting those conversations opened up and dealt with appropriately, and just getting everybody more working together to try and actually find a common solution. Even just discussing with my colleagues about weight management, or discussing with my colleagues about lipedema and how we manage this forward. And perhaps you don't need to give furosemide to these patients, or perhaps you don't need to give them pregabalin for possible for fibromyalgia, you know. And and when they look at the sort of educational advice that your website would offer, then they'd be like, well, actually, yes, I agree, they've got lipedema, this would be the way forward. But it would always come back to, what's the pathway for this? How do we treat it? Where do we refer them? Who will see the patients? For me, that's the important part to address, and to try get somewhere with pathway work for this.